Are we ready?
Okay, so welcome to the Public Board of Wye Valley for March. Really delighted to see members of the public digitally with us. And we start every board meeting with celebrating Going the Extra Mile winners. Our team award is, our team winners aren't able to join us today, but I'm delighted that Emma is able to join us, Emma Bell, our Employee of the Month. So digitally, we're going to give you a round of applause first. And then, Emma, I just want to read out what the sort of commendation letter said. So it was Tracy Hammer who wrote to us, and she said, Emma agreed to facilitate put my false teeth in. Emma agreed to facilitate respirator fitting for ICU staff to ensure that all clinical ICU staff could work safely within ICU when current FFP3 masks were in short supply. Emma went above and beyond to facilitate this. Emma currently works in paediatrics, and to ensure that both ICU day and night teams were fitted for respirator, Emma worked long hours on her day off. The ICU team would like to thank Emma for working above and beyond and supporting the ICU during these unprecedented times. Please, can you contact Val Johns by email, blah, 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 blah. So, Emma, I am delighted that you're winning, but as you well know, there are so many heroes that we have in the Trust who day in, day out, go absolutely the extra mile. And so I'm delighted you're the winner this month, but I'd also like to put on record the board's thanks to the phenomenal efforts of all of our frontline team, all of the domestics, all of those who work in canteens, all of those who are showing care out in the community. We as a board couldn't be more proud of everyone. But Emma, you are the winner this month. So again, another round of applause for Emma. So, Emma, you're... I'm not having a cardiac arrest. Emma, if you want to join us for the rest of the board, you're very welcome. But equally, I'll understand if there are other more exciting things that you want to do. But in the meantime, heartfelt thanks from all of us to you, and thank you for going the extra yard. Okay, team. So I think next month we're doing the Going the Extra Mile team winner. So we will wait for that. And we're a couple of minutes early before we can start the board. So I'll just have a drink, not of vodka. So Rhiannon, Nikki, Amy, I think this is all a new experience, isn't it? So shall I tell you what the board does and the way it sort of works? So what we do on a board day is we have a workshop in the morning, and at that we arguably talk about the more strategic stuff. So we've been talking this morning about equality and diversity and our big push as an anchor institution to really push an equality and diversity agenda, both within our trust and within our community. And we had a big discussion on the changes that are occurring in the NHS around integrated care systems. So that's the type of thing we've been talking about this morning. Then we're just about to go into the public session of the board, and that's where members of the public are able to join us digitally as well, but normally physically in the boardroom. And then at the end of the day, we have a confidential board where if there are any contracts or anything which is a bit sensitive, we'll talk about in the confidential board. So I tend to keep things going at a bit of a pace because I know how busy everyone is. So we will just get going because I am a stickler for time in just a second.
And for Russell and I, this is day 3 of 3 board meetings. We must do them in a different order sometime, Russell.
I think Wye's always the highlight of my week. Gives me the energy I need at the end of the week. And the other thing, guys, is you should never start a board meeting early. It's I did it once and made a major faux pas. So I never start them early. Always make sure they start on time. Okie dokie, team. So if we can use the chat box if you want to talk to me as we're going along, that would be great. But we'll get formally going with the board meeting. Delighted for members of the public who are joining us digitally or will be viewing this on YouTube in the future. It's been another very demanding couple of months for all of the frontline teams at Wye Valley. And we will discuss that in detail, obviously, during the board pack review. But I'd just like to put on record my thanks again to the phenomenal efforts of everyone in the Trust for trying to keep the people of Herefordshire safe. And we're making great progress in terms of the vaccine rollout, but I really would encourage members of the public, if you're offered a vaccine, to take up the opportunity to protect yourselves, but also to protect loved ones, to protect your neighbours and other members of the community. The fastest way we can get rid of this horrific pandemic is by having the vaccine, and in the meantime wearing a mask, keeping a safe social distance, and working at home if at all possible, and washing those hands for more than 20 seconds. So we have apologies from David Mowbray, and we have apologies from Rebecca Grattan at the moment. Any new declarations of interest?
Russell, it's Chris here. It's not a new declaration of interest, but it's just to advise the board that I will be demitting from office as chair of the local maternity and neonatal system on Monday. And my successor is Dr. Louise Bramble, a GP from Redditch. So it's just to advise you that I will be changing the register of interests. Okay, thank you very much, Chris. And Chris, you are a phenomenal servant to the Wye Valley board, but you've done some great work at the LMNS. So thank you very much. So moving on then, the last set of minutes of the meeting held on the 4th of February, was everyone happy with the accuracy of those minutes? Okay, super, thank you. And then the action points arising on page 16 of our pack. The first was Lucy to provide more in-depth analysis on the detail of the increase in the number of mixed sex breaches during COVID. That was done, thank you, Lucy. And then Jeffrey would review non-substantive budget establishment in future workforce reports, and that's been done. We'll pick up on that a bit later, Jeffrey, thank you. And then in terms of actions in progress on the emergency department transformation business case, we're going to produce a video, and Alan, I've seen some photographs circulating, but a video is going to be produced in due course. So thank you for that. That's a remarkably short list of action points arising. Are there any action points arising that colleagues feel I've missed? Okay, thank you. So we'll then move into the items for review and assurance, and the first of which is our Chief Executive's report. Glenn, over to you, please.
Thank you, Chairman. So I'm going to take you through a few things in the report today. Probably before I start, I'll just give a bit of a reflection on where we are from a COVID perspective. It's been really encouraging to see a reduction in cases in the hospital. So we're down to about 10 cases today. And that's fallen off quite a lot in the last few weeks. Now, there is still transmission in the community, but the whole objective of the strategy around vaccination that you referred to earlier was to ensure that we don't have hospital admissions and hospitalisation and mortality. So that's really positive. So I refer here to the National Vaccination Programme, which has moved on quite a lot since I provided this update. So I'm not going to go through the detail of that. Suffice to say, I think it was Secretary of State for Health referred to the positivity of the coverage of vaccination in the cohorts in Hereford and Worcester. But because it's gone so well, generally the timelines that I referred to in the report have been accelerated. So we should see, we've already seen good coverage in those high-risk groups, which is what is contributing to those reductions in hospital admissions, and long may that continue. One of the things we're worried about, though, as we roll out the vaccination programme, is that there could be elements of community that don't have access to vaccines. So And we worry that some of the health inequalities that already exist could be played out more as we roll out vaccination. So we've been doing some work across the group to look at a communications exercise to ensure that mainly our staff are aware of the issues. The internet's a fantastic thing, but it's brought with it all sorts of scare stories and misinformation about vaccination, as it has about COVID. So we're using our workforce in all three parts of the group to try and get some of those messages out, to encourage friends and family to take up the vaccine when it's offered, and to provide them with some materials that help them to address some of the mistruths. And as we look at our vaccination programme of our own staff, we've got good coverage of staff, but there's still some groups that haven't taken up the vaccine. So encouraging them to do so, as well as encouraging the members of the community that tend to trust them more than the politicians on these kinds of things. So then on the second page, talk about the ICS legislation that is going through its parliamentary process over the next few months. We spent some time this morning in workshop you referred to earlier, Chairman, talking about the local implications of this. And I think it's fair to say that we are in a very positive position in Herefordshire, where we've been doing some work already on trying to get ourselves in a position to be the lead provider in the place that we refer to as Herefordshire. The legislation absolutely supports the strategy that we've been working to for the last few years. It really focuses on place, it focuses on integration. And the feedback from the consultation on the legislation was incredibly positive. But there's one or two areas that they've strengthened, particularly the relationships with local authority colleagues, and ideally to build on the structures that are already in place for engagement with local authorities to ensure that it's a true partnership model for the NHS moving forward. I also refer at the end of that section to the fact that we were able to get ourselves in a position where we've been asked to look at how the implications of the legislation could be accelerated. So one of a few sites nationally, one in each region, that is helping to influence the way that policy is structured and to get a bit of help from the national team in implementation. And again, we talked about that earlier. We will, I'm sure, be discussing this in every single board meeting for the coming year as we move that forward. Then I refer to the Occupant Report, which we covered off in the main board meeting. As we exit COVID, we obviously will then need to look at how we handle recovery reset programme for the NHS, and we're already focusing now on some of those time limited surgeries that we need to ensure should take place. But what I refer to here are the routine waiting times particularly, and a need for the NHS to take stock of what our recovery trajectory should be. My suggestion to the national team here is that we don't move immediately from one situation to a situation where we're pushing our staff, who are generally fatigued at this stage, into a new set of standards for access times. That said, I think our staff all want to get back to normal. They want to get back to treating their patients. They want to get back to working in the teams that they joined, and that will help their health and well-being. So my suggestion is a new R word, because we've gone through recovery, restoration and reset, is respite. So a period of respite where we look at the new norm within the NHS, we look at our capacity post-COVID, and we start to think about how we can get back to a position where we're delivering access times probably to a new set of standards, and actually in many cases not going back to the way things were before. So I'll talk in a moment about outpatients, for example, where we really do not want to go back to a situation where every single patient is being seen face to face, where we've learned that digital is a good alternative to that. So there's some detail about some of our great teams. So a focus on our acute floor, so the emergency department, same day emergency care, and our acute medical unit. And the transformation that's gone on in those areas over the last couple of years actually has been tremendous. We were one of the early sites to implement 111 first. We were commended recently by Mark Doherty, the Executive Director of Nursing for West Midlands Ambulance, on our ambulance turnaround times. Usually when you get a letter from West Midlands Ambulance Service about turnaround times, it's not thanking you, but it was great to receive a letter from Mark setting that out, and we shared that with the team. And the transformation of those services has been tremendous. And in the middle of all of this, we also had, which you can see later on the agenda, an unannounced CQC inspection. CQC have carried out a small number of inspections over this period. They were very sensitive to the situation we were in, but it was a testimony to our staff that we got such a good report from that, which was published just a week or so ago, and we'll take that report later, so I won't steal anyone's thunder on the content of that, but a really positive outcome for us. The emergency department redesign, same day emergency care, and then at the end of that, the recruitment and retention of staff. So some really positive recruitment stories for the organisation. This morning we looked at the diversity of our workforce, and Jeffrey talks about 58, I think, but I think there's 60 nationalities if you count our UK and Irish to that list. So 60 international backgrounds that bring with our staff that huge diversity of experience and of skills, which is tremendous, which is why we've got such a fantastic service here. But it's great to see so many new starters helping to make us more resilient for the future. And then at the end there, we refer to the latest GEM Awards, which we were able to give out just before the start of the meeting. So I'm happy to take any questions.
Thank you very much, Glenn. Questions or perspectives to Glenn? Clearly an awful lot going on. Nicola?
Hi, forgive me trying to get off mute there. Yeah, Glenn, I mean, tremendous figures with the vaccinations. Hereford's done really well. We talked actually at workshop this morning, didn't we, about the lack of diversity in Herefordshire, and we know that there's obviously figures linked to vaccination take-up that link to demographic and ethnic figures. And I just wondered, are we comfortable that the number of staff in the trust, we know that is more diverse in Herefordshire? Are we comfortable that the vaccination figures for our staff are as high as we want them to be? And do we see that everybody we need to have been vaccinated in the trust?
Yeah, we're around the last data, and I'll explain the data in a moment. So there's a certain number of individuals that we vaccinate through our own processes, and then there's others that have been vaccinated out in primary care and indeed in any other centre in the country, and that data is a little bit later into our figures. So we're around the 70% mark at the moment, so it does need to be higher. And actually, one of the issues, again, to dispel the myths that are out there, is that there's not been a great take-up in young female staff. There's been some worry about the impact of pregnant members of staff or fertility concerns. And so that's one of the other things that we're trying to ensure that we address, because actually the situation there is that there just isn't enough, there hasn't been enough use of vaccine in pregnant women for us to say that there aren't any consequences of it. And that's what the national position has been on that. But actually it's a vaccine that's very much like the flu vaccine, which is very safe for virtually everyone to take. So trying to dispel those myths, because as soon as people say, well, there isn't the evidence, they assume there's contrary evidence which says there's a risk, and there isn't a risk. So we will be looking at the diversity, but also the age profile, sex profile of our staff for take-up, and if necessary, targeting those individual groups. But I would expect it to be similar to the levels that we've achieved for flu vaccination, which is certainly higher than that.
Thank you, Glenn. Thank you, Nicola. And Richard?
Yeah, just following on from that, Chair. Glenn, do you think we know enough about the reasons why people haven't had the vaccine? Because in some cases, and I know this from work that's been done on care home staff, some of the fears and worries are actually quite understandable. And there's a lot we can do to kind of persuade people.
Yeah, I mean, obviously we have been accelerating very rapidly the rollout of vaccinations. So and what we've been ensuring that we're doing is offering vaccines to staff, and there's been queues of staff wanting to have vaccines. So you then turn to those who haven't come forward, which is something we will be doing now and trying to understand what those issues might be. I think there's in some of the younger age groups, there is a degree of apathy that they're not the ones at risk, and they want other age groups to have access to what they see as a limited supply of vaccine. So there's a bit of that associated with it. But of course, if they are vaccinated, then they protect the patients and service users they look after, and it's just trying to ensure that those messages are understood. There's been some concerns about side effects of vaccines, but there's absolutely no issues other than a little bit of potentially a few hours or a bit of pain in the arm, but generally that's been a positive outcome. And as you've seen through some of the national data, the effectiveness of the vaccine is even greater than they originally thought. So some really positive outcomes of that as well. So we'll just keep passing on those messages. It's good to have role models that have been vaccinated and people telling positive stories about it. But the acid test for us is just looking at those numbers fall in terms of admissions to hospital.
Thanks.
Okay, great. Thank you, Richard. So we'll move on. I'm conscious of the fact some colleagues are having some stability issues on the internet, so please just persevere. We'll move on then to the Integrated Performance Dashboard. Jane, do you want to do the introduction to this, please?
Yes, I will do. Glenn's stolen most of my thunder, so I'll just say a couple of comments. In terms of our, we feel like we are coming to the end of this second wave with the reduction in patients who are in, but our second wave was 3 times as big as our first wave, both in terms of number of patients in ITU and in terms of number of patients admitted. So it really is a moment to pause and say thank you to all of our staff for just a huge commitment, hard work, flexibility, being redeployed at sometimes very short notice into different roles, having to access training in different ways, all of that. So it really is a moment to say thank you. And then I guess I probably just want to talk about 2 things that are worrying me. So the 2 things that are keeping me awake at night, if you like. One is, as Glenn mentioned, the number of patients who are now waiting for treatment. So we've got over 2,000 people now who are on our waiting list who have been waiting over a year. That's a huge backlog. Now, we've started to talk to our clinical teams about what's the best approach to that, specialty by specialty. There isn't any national guidance yet on the approach to that and the speed of reducing that backlog. But the most important thing to do is to understand from our specialties up their views on the right way to manage this, because they know their patients better. But I think it is a huge concern, and obviously we've had a depression of the number of patients being referred onto waiting lists during this time, and we expect that to bounce back as it did after the first wave. So it's just an added pressure of new patients on what's already a very large waiting list. So we'll be coming back to this time and time again over the coming months. And then the other thing that I'm concerned about is what looks like the national funding for the discharge to assess pathways being withdrawn from the beginning of April. I mean, there didn't seem to be anything in the budget about it yesterday, and that we did get given a sort of a very clear indication that was going to happen. So what's been happening over this past year is we've been discharging patients really effectively into the right place first time. So we've expanded community teams, more patients going directly home, but some of that is being supported by national funding, which looks like it's not going to be there in 3 weeks. So we're working very closely with the local authority and the CCG on how we can try and maintain those pathways, because it's so much better for patients to be at home at the time when it's clinically right for them, and not be constrained by the capacity of community teams. So that is a worry, and again we'll come back to that, but we are working very hard with the local authority and CCG on how we can maintain and fund those pathways. That was all I wanted to say.
Thank you very much, Jane. Any questions or perspectives to Jane? Or shall we dive into the detail? Nicola, can I just ask you to take your digital hand down, please? Okay, so moving on then to Lucy, first of all, on quality.
Thank you, Chair. I think this month I just want to talk about patient experience, if I may, and take the rest of the report as read. So board will recall that I made a presentation to the board at the back end of last year following the 2019 inpatient survey. And board members will recall that that survey identified that we had 32 areas of improvement. So 32 of the questions in the National Patient Survey were we needed to improve upon. And they were particularly around engagement, communication, information giving, and particularly engagement and information giving in the context of discharge. Since we presented that to board in October, we agreed that we would survey a sample of patients who'd spent one night or more in hospital every single month so that we got more regular feedback about their experiences. And we've been doing that since October of this year. And we've been using the same questions that are used in the national survey to help us correlate where we're making improvements and where we still need to focus our attention. I apologise that in the report there isn't any comparison to the data from last year's survey, but if I could just summarise. So we are still experiencing discharge delays, but where we have seen a particular improvement is in the time waiting, is the amount of people having to wait for medication and indeed the time that they have to wait. So we have made improvements there, which is good news given our previous discussions at Quality Committee, particularly around discharge medication. We've seen an improvement in patients knowing which nurses are looking after them. That was something certainly in the 2019 survey where we didn't fare well at all. Although there's, one of the major points in the patient survey was about patients feeling that nurses and doctors spoke over them or talked at the end of the bed as if they weren't there, and we've seen an improvement in that. However, the real areas for improvement are particularly around discharge. So where we've seen significant improvements is around people feeling that they have got more support and enough support from health and social care upon discharge, and that we're telling more patients who they need to contact if they're worried after they've been discharged from hospital. And also we've seen a vast improvement in the information that we provide to families, friends and carers around discharge. So that's all good news. We've still got work to do and we need to continue with that. As part of our surveying of patients each month, we've engaged with Healthwatch, who are doing follow-up phone calls with patients who've been discharged to understand more around their experiences from a qualitative perspective. And Healthwatch are due to attend our Patient Experience Committee in April to give us their feedback on that. So there'll certainly be more to follow in April at board. And then finally for me, just to give the heads up that board will remember we received, I presented the Infection Prevention Control Board Assurance Framework at the back end of last year. That was has been revised subsequently and was reissued in February. And there are 20 new key lines of inquiry. We're currently working through those and our intention is to bring that back to board next month. Other than that, I'm happy to take any questions.
Thank you, Lucy. Any questions or perspectives to Lucy? Chris?
Thank you, Chair. It was really just to give some more reassurance to the board. We've been concerned at Quality Committee and at board for some time about VTE performance, and we were pleased to hear that there's still innovative ideas being discussed and put into place to improve this situation, because we're not quite where we are yet. But I wanted to give some further reassurance to the board that other things are being explored to see if we can improve this. Thank you.
Okay, that's great. Thank you, Chris. And any other questions to Lucy? What's worrying you most at the moment, Lucy?
I think I maybe said this last time you asked me, Russell, but I think it's about staff's energy and resilience for the new normal. Because naturally, when it's been winter, we normally get a bit of respite over the summer months. And I'm not sure we're going to get the same level of respite over these summer months. So I think that's the thing that concerns me the most, Russell.
Okay, great, Lucy. Well, it goes back to Glenn's point on the importance of respite, because we are conscious of the physical and emotional exhaustion of our staff. Members of the public may have seen Channel 4's news on Monday and Tuesday, which had segments on it from South Warwickshire NHS Foundation Trust, which obviously Glenn and I also look after. And what really came across there were the human stories of the frontline teams. And I'm sure it's exactly the same down at Wye Valley. Okay, colleagues, I'm happy to move on to John's report. And John, if we can possibly pick up the issue which Grace has put into the chat box about the discharge delay in relation to medicines, if that's possible. Over to you, John.
Thank you, Joe. I think that probably relates to the last item, I would have thought, rather than mine, okay. But I can offer an opinion if you want.
Okay, Lucy, would you be in a better position to answer the question about the delay in the discharge delay in relation to medicines?
Yeah, I can offer a quick answer now, and then if you want more, Grace, I'm happy to pick that up outside of board. But essentially, we've had particular challenges within the pharmacy workforce around being able to provide support to all aspects of medicines management, and in particular around managing medicines for patients to take home. And the point I'm making really is that we've improved our performance in that area. So patients are having to waste less time for their medicines to go home. And that will partly be as a consequence of that our vacancy position, while still challenged, had improved during this period.
Thank you, Lucy. Okay, moving on then, John, back with you.
Thank you. I'll take the report as read if I may, Chair, and just pick out a few sort of highlights that haven't been covered by Glenn and Jane already, so which is not a lot left, but I'll try. Just generally then, demand, from a demand perspective, really, it's still quite a strange sort of position we're in. Emergency demand is down in terms of overall tenancies, and it's much lower than it was this time last year, or this time of a normal year, if you like. But conveyances are nearly normal, but they're very volatile. We'll go from a very, very calm day with perhaps 60% of normal tenancies to a greater than normal tenancies the next day. So there's a lot of volatility in emergency demand. In terms of planned care, 2-week referrals, as you'll see in the report, is I think it's a handful of cases, referrals short of where it was this time last year. You could argue there's been no growth, which we'd normally see, so we're maybe still a little bit behind where we would be normally, but it's very close, and it's certainly more than we expected after Surge 1. We thought we would be quite a few hundreds down on where we've got to, which is good news. That is good news, because we want those patients to come forward. However, both urgent and routine continue to lag behind, so the gap between year-to-date position this year and the previous year it continues to grow each time I report to you. So that's a worry, because obviously there are some people in need in those referral groups. So we still need to sort of address that in the fullness of time. In terms of performance, then, cancer 2-week waits we're doing pretty well on, actually. Patients are getting seen really quite quickly. And now the majority of diagnostics are happening quite quickly for those as well, although there's a bit of a blip in ultrasound due to high numbers of sickness and staff shielding, which has caused a bit of a problem. You'll see that diagnostic numbers rising. 61 days is a little bit behind. We've fallen away a little bit, mostly as a result of previous delays in diagnostics in a couple of pathways. But I'm assured by our cancer managers, I trust implicitly that we're only a week or two behind where we would normally be in terms of offering treatment. In fact, every patient now, as they TCI, as their decision to treat is made, is given a date by a multidisciplinary clinical panel who prioritise care into the resources that we've got available, which again, I have an awful lot of trust in. 18 weeks, James covered, but it is a real concern, and it's a real concern in terms of it's going to take some significant time to resolve that problem. Those 2,000 odd patients continue to grow at quite a rate. In fact, if you look in the pack, you'll see that rate of increase is growing rather than shrinking, because we aren't doing any routine surgery at the moment on this site, or indeed at the Nuffield. ED is more stable in the latter weeks as numbers are backed off. Flow continues to be a problem from time to time, but it's 1 or 2 days a week now rather than 5 or 6 days a week. And the diagnostics I've mentioned really are improving, and it's good to see MRI improving, because that seems to have plateaued a few weeks ago, and we now got reducing numbers of patients waiting overly long, which is really good news. And we have got some additional capacity coming next month, where we'll have actually 3 MRI scanners working for about 5 or 6 weeks before one goes offline to be replaced with a brand new scanner. So both bits of good news there, but we should actually be able to catch up and get back in real time. So there's some positive movements, but a number of concerns that still remain. I think that's all I wanted to say, Chair.
Thank you very much, John. And any questions or perspectives to John? Andrew?
Just on the diagnostics at the end, John, you mentioned it. The graph actually on page 36, I think it is, shows that it's actually rising again into a second wave, just to use the common language. And ultrasound seems to be maybe an underlying substantial issue of shortfall in capacity.
It's a specific workforce issue within ultrasound around members of staff shielding and some sickness, etc. That the team are working on. The management team in radiology are very capable, and they are putting plans in place, and they've got a recovery plan, so we expect to turn that around reasonably quickly.
Thank you, Andrew. Thank you, John. And we'll obviously come on to the issue of sickness, which is a bit of a worry. Any other questions to John? Andrew, if I could ask you to take your digital hand down, that would be great. And John, just how's it going with the Nuffield, given that they've been an important part of our capacity solution during this latest wave? And what are the future arrangements? What's the timing of the future arrangements with Nuffield, or the independent sector more generally?
I thought you might ask me what I was worried about, and that was one of the 2 things that I was worried about, was the independent sector. Obviously, the national and regional arrangements cease at the end of this financial year, and then we're into local arrangements, actually, which is what we've got in place. We managed to negotiate between ourselves and colleagues at Nuffield a very good arrangement where we've had very good access throughout to provide cancer services, and it's down to their cooperation really that we're in the position that we're in, where we're only a week or 2 behind where we'd want to be. So I am quite concerned. So I have had some initial conversations, and they're following those up tomorrow, about what will happen in April. We are very hopeful that we can open more theatres up in the next 10 days or so, and get more ward beds committed to elective care. So we should be a little bit more self-dependent, self-reliant before the end of March. But I'm hopeful that we can negotiate a reasonable position with the Nuffield to continue doing a volume of work that helps us through this period, which will take a bit longer than we'd all want as we try and recover normal full working.
Thank you, John. And what's the other thing you're worrying about?
D2A.
Okay.
The cessation of that arrangement as well is a concern, because that's I think it's lots of positive things, not least the fact that it's got people into their home and into a safer environment quicker, and we've avoided an awful lot of hospital-acquired functional decline, etc. So it's done all the right thing, but it's also kept our beds free to allow us to cope with COVID. So I think it was one of the best things we did through COVID, really, in terms of making sure that people got to the right place first as soon as possible, rather than keeping them in hospital necessarily.
As we've said time and time again, it's always about keeping the flow going and minimising unnecessary length of stay. Thank you, John. Colleagues, happy to move on to workforce and Geoffrey? Geoffrey, over to you.
Oh, thanks, Russell. I mean, I guess the key thing within my report would be we've seen an increase in sickness absence over the last few weeks, and also we still seeing some concerns around performance appraisals. Both have really been impacted upon by COVID, and as we go forward, we should expect to see some improvements, certainly in terms of reduction in sickness absence, and also people having more formal performance appraisals. So we're doing everything we can, working with our staff side colleagues, occupational health, line managers, just to ensure that we're putting in the right support systems in place to support our staff, because we know it's been quite difficult for lots of colleagues over the last few weeks. But certainly as we going forward with a reduction in COVID-related sickness or cases, the situation should improve. So that's where we are with that. The final page of my report captures some key HR OD developments, and just two key things. We started the massive recruitment campaign to recruit up to 82 healthcare support workers over the next few weeks. So if there's anyone out there, I think, looking for jobs, this is the right time to really come and join Wye Valley. So that recruitment campaign is ongoing. We also working with Herefordshire Council on the National Kickstart Placement Program. So this is a program for young people whereby over a 6-month period, you get a paid placement to support Wye Valley. So if there's young people out there who are interested in this scheme, now's the right time as well to get in touch with Wye Valley. So we'll have the results of the 2020 staff survey by the time of the next board meeting. So I'm sure we'll be able to share some of that next time. And also the NHS People Polls survey, we should have the most up-to-date results as well by the time of the next board meeting. And we will share the key information coming out from those surveys. That's all I wanted to highlight, Chair. Happy to take any questions.
No, that's great, Jeffrey. Just before I open it up, just to reinforce what you said there, a career in the NHS would be a great decision for any young person. The variety, the opportunities, the comradeship, doing social good, but working for an organisation that prides itself on being exclusive, open, empathetic. We are very values focused. So if you want to make a difference with your life, with your career, as Jeffrey said, come and apply to us. The world's your oyster. And on the subject of someone who joined as man and boy, the first question, the NHS, the first question goes to Glenn Burley.
Yes, that was an awfully long time ago. So, I mean, the sickness levels, as you suggest, Jeffrey, is something we need to keep a close eye on. And obviously, we can imagine that it's COVID related, but I think it's also important for us to make sure that we do some analysis on that. The other one that stands out in the pack for me is on page 49, which looks at the staff satisfaction of new members of staff, and it indicates some of our recently joining nursing staff and midwifery staff are less satisfied. Now, again, that could be because they've been redeployed on arrival and it's been a really difficult period. But again, I think it would just be useful to make sure there's not anything else that we need to respond to.
No, absolutely. I mean, obviously, Glenn and I see the statistics from other parts of the foundation group, and at the moment, Wye Valley in terms of sickness is definitely an outlier. And Frank?
Can I make an observation? Thanks very much for the information on exit interviews. It's really good to see that we're getting that detail. One of the things I think might be helpful for the future is to watch the trend of things we can control and things we can't. I mean, you could split that into a percentage of things that are in our gift and things that are not. And I think it'd be ideal to be able to see how that changes over time, rather than just a specific picture. Thank you.
That's a good suggestion, Frank. Thank you. Any other comments from colleagues? Otherwise, we'll move on to the money. So, Howard, tell us about the money.
Hi, yeah, thanks. So at the end of January, we were reporting a surplus of £2.5 million and were forecasting a cautious £2 million surplus at year end. I think, having said those are very sort of positive figures, I think I do need to stress that we've received as much as £35 million more than if it had been a pure PBR income follows activity equation. So we've received a lot more income than we would have expected. In the 4 months, in the last 4 months, we've incurred about £2.4 million worth of expenditure related explicitly to COVID against a £5.7 million allocation. And we've so far spent £9 million additional directly as a result of COVID over the course of the year. This month we've reintroduced an accrual for unused annual leave. This has been at the request of the National Health Service, the national body. Colleagues may recall that we used to do this, but the approach was dropped a few years ago, but there has been a national push to reintroduce it. As a result of the impact of staff being unable to take leave because of COVID. You'll notice in the report agency nurse costs are running at a slightly higher rate than at the end of last financial year. But in the last month, medical agency saw a material reduction, which is positive. In relation to capital expenditure, we're working hard to maximise the use of capital available and to work it so that we can carry as much forward as possible to benefit us next year. But it has been an incredibly unusual 2 months. We've been absolutely inundated with capital, seemingly as national departments have cleared out their own books, and most of it we've been given with an explicit instruction to spend by the end of March. And we all know that that sort of year-end rush doesn't always lead to the most effective use of capital. But we have done our best to, one, make the maximum use of it, but also to make sure that we're buying the things which are most urgently required. Alan and I and colleagues have done our best to try to make sure that we've identified the critical issues. And if we can buy them this year before the end of March, that actually takes the pressure off for next year. So that's all I was going to say about the financial report, but happy to take any questions.
Thank you, Howard. Any questions to Howard? Sorry, Andrew.
Yeah, I'm hesitating a bit, but I can't believe I'm asking this. Should we make a surplus?
Hi, Russell. This is Dr. Verdi here from the dental practice. You referred to me.
I mean, I was, you know, I mean, firstly, I presume, Howard, you're ensuring that there's no burden from this year that will find its way into next year. And also, in the good old days when I was a lad, there were brokerage arrangements to be had at different levels. And we've got losing funding for a very important service established this year. Could we find a way of...
Yeah.
I suppose as an ICS, should we be saying, should we be supporting every organisation breaking even rather than some having a surplus and some not? I can't believe I'm asking the question, but
no, it's a great question. It's a great challenge, and I think the fact of the matter is this is such a different year. I mean, there is a higher level of scrutiny going on in terms of what we're actually reporting than I've experienced for some time, if I'm honest. We also, of course, have new auditors this year who are taking a very, very close look at our expenditure. So I and my team are doing everything we can to ensure that we deliver an appropriate position this year and looking for opportunities which could help us next year. But I think even with that, given the huge amount of additional income which we have received this year, and given the way the cost has absolutely reduced materially, the opportunities for us are quite limited, if I'm honest. So we're conscious of it, aware of it, trying to do our best, but I think that we will end up with a surplus despite all that.
Thank you, Howard. Glenn, is there anything you want to quickly add on that?
Yeah, I mean, just in terms of the question itself, we are allowed to make surpluses. In fact, that was the original intention, wasn't it? All those years ago when they set up the regime, and that would be retained. It's an unusual situation for us, but the way that finances are being managed now are that our surplus contributes to the STP overall financial position, which when you add it all up is not in surplus. So it is helping the kind of wider STP.
Thank you, Glenn. Colleagues, happy to move on?
Thank you, Howard. And the trust objectives, Alan.
Thank you, Chair. I'll take the report as read. I'd like to introduce the trust objectives for 21-22 for approval. These will form the key priorities for the coming year. Although the caveat there is that the national planning guidance for the next financial year isn't out yet, and planning's been rolled forward into Q1 of the next financial year. It's linked, as you'll see in the report, very closely to the trust strategy around the 4 sort of tenets of our strategy. And in there, you'll see that there are some group objectives that we've agreed with the 2 other organisations in our group, and they are reflected, although not word for word, but are certainly reflected in the objectives that we've worked up. These all form the basis of objectives for divisions and in turn teams and individuals, and will be linked to our operational plans, and in time we'll have measurables very much attached to them. My intention is to report on objectives at 6 monthly sort of intervals throughout the year, so to do an end of year wrap up as well. And I suppose I won't go through them in individually, but I suppose there are a number of themes in here. I mean, some of the objectives have been rolled over from previous year because it was felt to be it was worthwhile to continue to work on them. The IT strategy is a good example of that. It's an ongoing key strategic piece of work, but some of the themes I would say, one around integrated working, and as a board we talked about this at length this morning in the workshop about how we work closely with our partners in an integrated way, and this is heavily reflected in these objectives here, preparing the organisation for that kind of matrix management working with partners. The second one I would say is something around quality improvement, and I would also say obviously our recovery and response to the COVID outbreak and all the effects that that's had on the organisation and our workforce. And workforce are an absolutely key theme in here. Working with them to both address the patient care issues caused by COVID, but also the issues for them and their health and well-being. So happy to take any questions.
Thank you very much, Alan. We've obviously been on this journey with you. Jane, anything you want to add?
I think Alan's put it very well. As I say, running through that is that theme of integration, partnership, working, and as I say, and it is the implementation of the strategy that we've had in place for the last 3 years. So it's really good to see such good progress.
Great. Andrew, is that a legacy hand or a new question?
No, just it's a question, sort of comment on. I've had this discussion by email with Alan. I suppose I feel that there should be mentioned somewhere in there finance, maybe not as an objective, but even if it was just recognition within the introduction that actually all this has to be achieved within a fairly tight financial envelope.
Yeah.
Just a framework or a sense that we recognition that the board attaches.
Yeah, I mean that's obviously that's the important emphasis, and it's I suppose we've not put it into these because it's something we kind of take for granted a little bit. But just to answer that point, under number 7 on sustainability, we've obviously making reference there to the COVID recovery plan focusing on improving system productivity. So the productivity focus and the way that we recover from COVID is very much going to be helping to drive our efficiency program, which will allow us to operate within the financial envelope that is finally agreed. And as Howard has already explained, we've still got some hybrid arrangements going on here. Just if I may add though, Russell, the big one for me is that final objective 12, which is the workforce health and well-being, which you've obviously talked about a few times already today. Just to note that one is one of the objectives we are working on across the group, and these aren't the group giving us objectives. These are things that we recognise that if we work together on them, we'll get some better solutions together. So we're giving some time to that at the next group strategy committee.
Thank you, Glenn. And Chris?
Thank you, Chair.
Sorry, Andrew. Sorry, Chris. Sorry, Andrew. Did you want to come back?
Yeah, it's just that I don't know whether Glenn was saying the document would reflect. I take your point that we take it for granted that there is this, but this is assumption about finance. But this is a public document going out into our organisation, quite rightly. I just think it should reinforce it, or just remind people.
Okay, we'll endeavour to cover that off in the narrative that goes alongside it, just to make that absolutely clear.
Yeah, no, thank you, Glenn. Thank you, Andrew. Chris?
Thank you. Embedded in number 5, it talks about improving our informatics capability. I would just re-emphasise the need to relook at our internal informatics capability. It's not quite as nimble as it needs to be when we're looking at KPIs, for example, and we've struggled over the year with that. So I would just urge that we don't forget about that as well. Thank you.
Lots of nodding heads, I think, from Jane and Glenn. So that's recognised, Chris. Thank you. And finally, Frank?
Yeah, picking up on Glenn's and Andrew's points, the group objectives, we've chosen 5 bullet points, which tends to give emphasis. And yet I know that we're giving a lot more than that emphasis to health and well-being, which is covered in item 12. And I just think from a public perception point of view, we should make sure that reaction isn't seen by others, because that was my first reaction when I saw those 5 bullet points, that I was disappointed not to see health and well-being of the staff in there. We've just heard how important it is, the biggest worry Lucy's got and Glenn's got in the respite comments. So I just think we've got to be careful about the way we present this and give it suitable emphasis. Thank you.
No, thank you, Frank. And I think that's agreed. Glenn?
Yeah, the wellbeing one should have been on that list, actually. But yeah, the way we present it, I completely agree. We just need to make sure that comes out very clear that that's one of our number 1 priorities.
And Jane, were you raising your hand to say something?
Yes, I was. I forgot to raise my blue one. And I think that it's the way we present it to the organisation here that's really important. And our intention, in a sense, almost isn't to mention the group objectives in the way that they're written in this document, because those group ones are incorporated into our objectives. So, I mean, it's got to be meaningful to our staff, and the fact we're working with our group partners, it is only important to those people who are working with partners. It's not important to everybody. So it's about getting the message right to ours. So we'll focus on the 12 organisational objectives, but knowing that they're informed, and more importantly, there's additional support and capacity available to deliver them, because we're working as part of the group.
Yeah, as ever, people naturally think that the last thing they see on a list, even if it's called a priority, is the least important priority. And that's what we need to watch on this issue of staff wellbeing. And finally, Lucy?
I think just to say that obviously once the trust objectives are agreed, we always then work up a set of quality priorities that form part of the quality account. And the intention is to bring the draft quality priorities to quality committee at the end of this month, and then we'll bring them onto board as well.
Okay, super, thank you. So in the context of all the comments, I mean, Andrew's absolutely right. Financial sustainability has got to be the bedrock of what we achieve going forwards. Difficult to see given the way the numbers are looking for next year, but we need to be explicit on that. And staff wellbeing is a cornerstone of what we need to build our future success on. Our staff are everything. With those comments in mind, if you're not happy to approve these objectives, please raise your digital hand. Okie dokie, thank you. Duly approved. The digital programme update report, Howard.
Thanks very much. I'd like to take the report as read. 2 points, though, I'd make. One is that hopefully you can see from the report that we continue to make good progress despite the challenges of COVID. And secondly, it's pleasing to reiterate the fact that we did pass the final funding milestone of the global digital exemplar. We've received an email from the NHS Digital this week congratulating us on that. but also pointing out the need for us to continue working hard on implementation to, one, deliver full benefits, but two, to make sure we achieve what they call HIMSS level 5, which is a level of digital maturity. And that's very much what our digital strategy, which was agreed at the December board, strives to do. So yeah, continuing to make good progress, but happy to take any questions on the paper.
Thank you very much, Howard. Any questions or perspectives to Howard? Let's aim for hit. Sorry, Chris.
Thank you. The progress has been astounding, and I just wanted to reflect. Last year, we were a little concerned with responsiveness of our IT supplier, Maxims, and this seems to reflect very well. Are those concerns been put to bed now?
Yeah, thanks, Chris. Yeah, I think that, I mean, we've worked hard with IMS. I mean, you could argue that the fact that they have had a fewer people to concentrate on, you know, have developed a very good close working relationship with us, has benefited us. But we have worked hard on that relationship, and I also think that the focus that the whole global digital exemplar initiative has had on us and making sure that we focus on the most important things has also helped the program. We did appoint a new program manager, Bethany Mowat, who has actually been with us for over a year now, and she has made a real difference. So you know, I think it's a number of factors, but thanks for the comments.
Good.
And also thanks to your leadership, Howard. You know, don't underplay the role you've played in steering the ship. So thank you. Colleagues, happy to move on. Therefore, the policy panel, Erica.
Just to provide a routine update, Chair, on the policies that have been reviewed by the policy panel to just keep our policies updated and in a consistent format. So they are all linked there.
Great, thank you, Erica. Any questions on the policy panel? Okay, thank you. And therefore, we'll move on to the CQC report, the ED inspection. Jane?
I think it's John actually who's going to talk to this one.
Okay, it's you on the agenda, but we'll pass it over to John.
John wrote the report.
John, are you with us?
I am sorry, I do apologise. I just lost it for a second there. Where are we?
We're on the CQC, the highlight of the whole board, actually, John. The CQC Emergency Department inspection report.
I do apologise. I really wasn't expecting to talk to this. Right, so I think I think Jane alluded to it earlier on. We were inspected, I think, in December. Sorry, I think Glenn put his hand up then.
I was just going to offer to take it if no one else does, because I'll take the credit for it.
Yeah, absolutely.
But no, I mean, tremendous work from the team on this, because I mean, one of the things that we just need to emphasise here, as I did earlier, is that this was alongside obviously a difficult COVID scenario in the middle of winter, and you know, inspections in the middle of winter are never a great thing. CQC decided to look at a number of trusts based on data. So they obviously looked at some of our performance data and decided they needed to come in and check that things were safe, which is what they did in this inspection. Very pleased to see a number of really positive things that they identified, particularly the culture of the organisation, the support of the leadership team. They identified some areas where we can make some improvements, and we quickly picked those up, some of which were actually some of the compromises we'd made around the way the department functioned during COVID, particularly the way that we were trying to find some additional space to create an area where staff could doff and don their PPE, which we will, with the further expansion of the space that we referred to earlier, that will be no more of a problem. Obviously talked about some of the ideas that staff have got about making improvements. So in the scheme of things, the best result we could get was to maintain our good rating, which is what we did. One of the things I'm very keen for CQC to do before too long is to find a way through their current situation, because they are obviously not doing the inspections in the way that they did in the past. And armed with this, I'd very much like them to come back and inspect lots of other things to try and get our rating up to where I feel it could and should be. And so there's a process going on at the moment where CQC are looking to see whether they can use other intelligence in order to review organisations' ratings in an upward direction. But bearing in mind they've targeted inspections in a number of trusts and found issues that have led to concerns being raised, this is one of the more positive results I've seen from those inspections during that period. So if no one else wants to, I'll say it's a great report, and happy to take any questions and then pass them on to the relevant exec.
So thank you, Glenn. Any questions, Richard?
Yeah, I mean, I thought it was a fantastic report. To get a rating of good in the middle of a global pandemic in the winter is absolutely fantastic. You know, we should be putting out the bunting. What irritated me about the report was the CQC front sheet, which conveys the impression, unless you read it, that this is an inspection and a rating of the whole hospital, when it isn't. And I think that's incredibly misleading and unhelpful, and we ought to feed that back.
Yeah, no, duly noted. Thank you, Richard. Any other questions or perspectives? Lucy?
I was just going to say we did challenge that as part of the factual accuracy and said it was a little bit confusing to see the overall ratings on the front, but that's how they do them for everybody. So.
Okay, thank you, Lucy. But well done, team. As Glenn has indicated, it's a great success. Jane now wants to come in and take the glory. Jane.
Found my voice. I'd asked John to write the front sheet for it, so I sort of just assumed it was with John, and so I didn't want to take John's glory. But yeah, I mean, I think it is a sense of enormous pride actually in this team. And if we go back, 3-4 years ago, this is the area. This was the burning platform. We were really worried about urgent care, and it's where we started, in a sense, our new approach, that we would work with the staff on the front line. We would get them to come up with the ideas. We would get them to drive the change. And here we are 3 years on, and it demonstrates what that approach can really do. So yeah, I think it's just huge pride in this team and what they've achieved.
Okay, team, colleagues, happy to move on. So I think we're then on to the Quality Committee of the 28th of January. Chris?
No, Chair, just to report though, for those who are not aware, this is just a shortened agenda, but dealing with the important issues that we needed to at the time, but no other to report.
And the 17th of December, Chris, anything you want to add to that? And then I'll take questions after both. No,
Chair, the same applies.
Thank you. Any questions or perspectives on either the 17th of December or the 28th of Jan QUAC meetings? Thank you to everyone involved and Chris for chairing. I think then we're on to any other business. Any other business? Howard?
Thank you. I thought I ought to just take the opportunity to report to the board about the arrangements around the annual accounts this year. What has happened, the trust has been, as all trusts have been given what's essentially a normal time frame for the completion of the accounts, which is the end of April. Because of the difficulties of conducting audits during the pandemic, the auditors were then given the opportunity to have an additional 2 weeks to conduct the audit. Consequently, we rearranged, colleagues may or may not have noticed it in their calendars, but we rearranged the final audit committee of the year and the final accounts board meeting, moved it back from Thursday the 20th of May to Thursday the 10th of June. And then another missive came out from the centre saying that actually if auditors felt that they were still going to struggle to deliver with the extra 2 weeks of audit, they could actually have even further, another 2 weeks. And our auditors, who of course are auditing us for the first time this year, they actually raised a hand and indicated that they were concerned about getting everything done that they have to do in the period between the end of April and the 10th of June. So consequently, what we have now done with the agreement of Chair and Chief Exec is that we have agreed that we will put in the diary a contingency extra audit committee for the Thursday, the 24th of June, and asking the board to give that audit committee devolved responsibility for approving the accounts. And then if that was to be the case, then the accounts would go for the formality of board approval at the Thursday, the 1st of July board. The final deadline for the accounts is the 30th of June. So that's why we would have to do it in that way. But what we didn't want to do was keep on rearranging audit committees, rearranging boards, and we needed to get some certainty into the board calendar. So I hope that explains why the meetings have moved once and why a contingency meeting has appeared in the diary. Happy to answer any questions.
No, that's great, Howard. And this is obviously your last financial year, albeit it's not your last board meeting, but it looks as though this financial year is going to end on probably the highest of highs in terms of the numbers that you've been able to oversee. Any other business, Frank?
Yeah, if I may, Russell, I could have said this several times during the meeting. I've been around a long time, as most of you know, and I've never seen so many reports that show such great achievements right across the board. National recognition, targets met in the most awkward circumstances. And I'm finding it difficult to find words because everybody keeps talking about the great work, but somehow I'd like to think the organisation can express some recognition from this board as to what's been achieved. Thank you.
No, absolutely, Frank. And I think that it's also for you as a group of executive directors, you're doing an extraordinary job of leadership. And, you know, I personally can be very sad when it comes to you going, Howard, but you've done a great job on a number of fronts. It's great that Jeff's joined. It's just great we've had the stability of John and Lucy with us, so, and Alan. So it's a great team effort, and you know, Jane and under your stewardship, the executive team are doing a great job. So well said, Frank. Okie dokie. Well, I think our next board is on the 1st of April. Look forward to seeing you all then. It's not an April Fool's joke, but in the meantime, for members of the public, if you are offered a vaccination, please take it up as soon as possible. We need to get the total population vaccinated to the order of 70 to 85% to get herd immunity from this awful pandemic. It is essential for you to go and have your vaccination done. And until then, and even once you've had it done, please continue to wear a mask, continue to socially distance, and continue to wash your hands. In the meantime, take care. Thank you very much.